Hello guys, Dr. Lalkrishna here, and today we'll be discussing about thoracic trauma. So we are in the sixth lecture of the NEET PG series in the trauma series. So today we'll be discussing about thoracic trauma. The link for the notes is given in the description and on my Telegram channel, that is Pehel Free NEET PG Coaching. You can download it from there or you can find it on Telegram. So without further delay, we'll start. Before starting, I would just like to thank and pray for 1 minute for showing gratitude towards our teachers, parents, and God, so that we are able to serve and do our duty in a better way. So we'll start with the discussion of thoracic trauma. So thoracic trauma is very common in polytrauma patients who have sustained multiple injuries, and most of the time it can be managed without any intervention or surgery, but sometimes it can cause life threatening injuries, so we have to be careful. So we have some 12 injuries which are very dangerous, and some 6 of them can be very life threatening, like immediately they can cause death and should be detected during the primary survey. So what are these 6? So if there is airway obstruction, then it's a problem. We have to find it out and take care of it. We have already discussed about airway in our basics of trauma session. Then coming to tension pneumothorax, that which we'll see today. Sorry for this. Then pericardial tamponade, which again we'll be seeing today. Open pneumothorax, this we'll be seeing today. Massive hemothorax and flail chest. To just give you an overview quickly, so what is pneumothorax? Where the air is trapped between the pleural cavity. In hemothorax, there is blood in the pleural cavity, and in pericardial tamponade, there is blood or fluid in the pericardial space due to injury, causing difficulty in circulation, in respiration. So all these things will affect. And flail chest is um, injury at 2 consecutive ribs at 2 or more places. So 2 consecutive ribs, fracture of ribs at in 2 consecutive ribs at 2 or more places. So this is flail chest. So these are immediately life threatening. So within minutes to hours, within 1 hour, most of the time it can cause death. Sorry for the disturbance. So now we were discussing what are the potentially life-threatening injuries which should be detected during the secondary survey rather earlier, because they can also be life-threatening after some time, if not immediately. So what are these? These are aortic injuries, tracheobronchial injuries, myocardial injury, myocardial contusion, diaphragmatic rupture, esophageal injuries, pulmonary contusion. So this is some of the injuries which can cause death after some time, so we have to be careful regarding these. So now coming to the mechanism of thoracic trauma. So blunt thoracic injury is most common, and most common cause of death in blunt thoracic injury is tracheobronchial injury, which causes death. And in case of penetrating injury, the most common cause of death is hemothorax due to pulmonary laceration. So what are the investigation which we do for thoracic trauma? So first is the chest x-ray in the anteroposterior view. That will give us a rough idea of the hemothorax, pneumothorax, even pericardial effusion. Then secondary we have E-FAST, which will help us in evaluating lungs, heart, and even abdomen for any collection. So what are these sites? So first is the Ziphis uh, subxiphoid, that is the first one. Pericardium, where we see the pericardium. Here we will be able to find out if there is any pericardial effusion or cardiac tamponade. Then in second one, in the right upper quadrant, in the Morrison's pouch, whether there is any free fluid in the abdomen collection. Also in the pleural space, in the left upper quadrant, in the free fluid in the peritoneum, again whether there is any fluid in the pleural space, left upper quadrant. Then suprapubic area, whether there is free fluid in abdomen, peritonitic features, or blood in any fluid in abdomen, that will be able to detect suprapubic area. Then both the thorax, fifth and sixth. So these are the sites where we check in the E-FAST, extended fast. Now this is the diagram of actual image of fast. Sorry for this. So here we can see, here we are checking in the right upper quadrant. We can see the liver and the Morrison's pouch. We can see the pleural space. In this, in the left upper quadrant, again we can see spleen and we can see the pleural space, the costophrenic angle. Then here we can see the suprapubic region where we can see the bladder in the fast. Then here in the subxiphoid we can see the heart with the liver, and here the stratosphere sign where we see the lungs and the pleural space. So this is basics of ultrasound, and every MBBS doctor should know this and try to learn this so that in case of emergency you can handle and detect emergency situations earlier and manage them well. So now coming to the injuries one by one. So most commonly these injuries are, most common type of injury in thoracic injury is the rib fracture. So it is more common in adults than children, because the children's ribs are more pliable and they are in the developing phase, so they don't get injured earlier, jaldi nahi टूटते वो. Then what is the clinical features? दर्द होगा, pain, bruising, वहाँ पे खरोच आएगी. Then management, we generally just have to give them good analgesia, and by depending on the pain sensitivity of the patient, we may extend it up to like epidural analgesia, even that will help. The highest one is epidural analgesia, and we avoid strapping because strapping affects inspiration and can cause atelectasis and also pneumonia. It causes more pain also. So it is avoided, strapping is avoided. So in case of CPR, the most common fractured ribs are 3 to 5th ribs, and the first rib is fractured only in cases of high velocity impact, like in case of very high velocity vehicle crash, RTA. So if first rib is fractured, what injury we can see? Subclavian vessels injury, apex of lung and brachial plexus, all these can get injured. Then fracture of floating ribs, these can occur in high velocity impact. injuries and can be associated with splenic and liver injuries. So this was all about rib fracture. Now we'll be seeing flail chest. So what is flail chest? Flail chest is two or more consecutive ribs, at two or more places. So it is very important that we understand that if we are having rib number 3, then there should be two fractures in rib number 3, and then in rib number 4 again we should have at least two fractures. It should not be like that two fracture in the third rib, one fracture in the fourth rib, and two fracture in the fifth rib. Please try to imagine and understand how is flail chest. Two fracture in third rib, two fracture in fourth rib, or two fracture in third rib and three fracture in fourth rib. So consecutive ribs, two consecutive ribs, two or more places. So even if it could be even three, like second, third, fourth, three ribs, each rib having two fractures, so that will form a flail segment of the injury. So this is how, what is the definition of flail chest. Hope you have, it has been understood. दो कॉन्जिक्यूटिव रिब यानी एक के बाद एक, दो कॉन्जिक्यूटिव रिब में दो से ज्यादा जगह पे फ्रैक्चर होना चाहिए, ठीक है. देन कमिंग टू क्लिनिकल फीचर्स, एज कॉमन पेन, इंजरी है, पेन होगा. रेस्पिरेटरी डिफिकल्टी इज अ पॉसिबिलिटी, सांस लेने में दिक्कत होना. देन पैराडॉक्सिकल चेस्ट वॉल मूवमेंट, दिस सब नॉट सीन इन ऑल, सो ये सब में नहीं दिखेगा. व्हाट इज पैराडॉक्सिकल चेस्ट वॉल मूवमेंट? नॉर्मली चेस्ट वॉल कैसे मूव करता है कि सांस लेंगे तो छाती बाहर आता है, सांस छोड़ेंगे तो छाती अंदर आता है. सो इसमें रिवर्स होता है. तो इसमें क्या होता है कि सांस लेगा, है ना, सांस लेगा तो छाती का जो वो फ्लेल सेगमेंट है, जो टूटा हुआ हिस्सा है जो अलग हो गया है चेस्ट वॉल से, वो सांस लेने पे अंदर आएगा और सांस छोड़ने पे बाहर जाएगा. Getting my point? The flail segment detaches from the rest of the chest wall and flail segment moves in with respiration and out with expiration. So hope it has been understood. Then coming to, it can cause pulmonary contusion, flail segments, and it can also cause death. And how do we manage flail chest? So very important, adequate analgesia. We can also give thoracic epidural as the best pain management for this. And then oxygen therapy if required, rather most of the time it is required. And if this fails, we can go for intermittent positive pressure ventilation if the respiratory rate is more than 20 or PaO2 is less than 60 mm of Hg. So that means that the patient is in respiratory distress, respiratory difficulty. So we can understand. Then coming to IPPV, it also acts as a pneumatic splint, like it's a supportive protection, pneumatic splint. Splinting is giving support. So this is pneumatic splint. So splint with the help of air. So if this also fails, then we will have to give surgical splinting with the help of wires which we use to fix the chest wall. So this was all about flail chest. Now coming to pneumothorax. I'm sorry for the diagram, but I have posted this diagram earlier. Hope it is visible. So now coming to pneumothorax. So here what happens is there is air in the pleural space. So between the two layers of the pleura, the parietal and the visceral pleura, there is air filled in it. So that means pneumothorax, and it is an emergency condition. So there is accumulation air in the pleural space between the two layers of pleura, that is the visceral and the parietal pleura. So it can be of two types, rather we can call it as three types. So it could be simple pneumothorax, tension pneumothorax, and also open pneumothorax. So what is simple pneumothorax? So air in the pleural space with no hemodynamic compromise. So this is simple pneumothorax. Like there will be no derangement of vitals like BP and heart rate and respiration. Then coming to tension pneumothorax. Coming to tension pneumothorax. So what is tension pneumothorax? If it is associated with hemodynamic compromise, like if the heart rate is very much more than 100 and the BP is falling around 100, 90 or 80, something like that, and respiratory rate is more than 20, 30, then it is tension pneumothorax. So we have to understand and work quickly because it is an emergency. And you may lose the patient at any moment if delayed, be delay in management. So how does it develop? So if there is a tracheobronchial injury, the tension pneumothorax can develop in a tracheobronchial injury, or if there is large pulmonary laceration with air leak, that is a closed pneumothorax, or IPPV being done without chest tube insertion in a closed pneumothorax, or an open pneumothorax where there is a wound in the chest wall, and to protect this wound we should keep it closed by 3 sides and keep one side open as one valve. So that was the part of management for open pneumothorax apart from putting a chest tube. Then we have to be quick in our management because within minutes to hours the trachea will shift to the opposite side and the lung will collapse and there will be decreased air entry and there will be respiratory distress. So patient will be having difficulty in breathing. So coming to pneumothorax, the tension pneumothorax. The tension pneumothorax, the lung on the side of the is compressed against the chest wall and cannot expand. So lung is compressed, okay, and cannot expand. So there will be respiratory compromise and again even the heart will be affected. So there will be cardiac compromise. So these both things will cause difficulty, emergency, and may cause the patient to die. So we have to be very quick. So there is pressure, there is tension in the pleural space that is causing the lung to go to the opposite side and not able to expand fully. पूरा lungs expand नहीं हो पा रहा है, खुल नहीं पा रहा है, सांस नहीं ले पा रहा है, उसकी वजह से lungs भी compromise हो रहा है, respiratory pathway एंड हार्ट भी कॉम्प्रोमाइज हो रहा है, सर्कुलेटरी पाथवे. तो दोनों वाइटल ऑर्गन्स अफेक्ट होने की वजह से ये बहुत लाइफ थ्रेटनिंग कंडीशन है एंड इसको क्लिनिकली डायग्नोस कर सकते हैं and we can act upon it to save our patient. So what are the clinical features? Tachycardia, rapid heart rate, it could be more than 100, decreased cardiac output due to compression of the heart. So cardiac output decrease होगा तो BP pulse volume कम होगा. We can see that there will be weak pulses. Then again tachycardia, heart rate is more. We have already discussed tachycardia and pulses will be more. We can feel the pulses, low volume pulses, weak pulses. Then there will be decreased systolic blood pressure will be low again, it could be 90, it could be 80. Raised JVP, which we can see in the form of in the neck, raised JVP. So these are some of the clinical features we have to understand. There will be no breath sounds, that is very important. In these signs we have to take care, no breath sound, and percussion will be hyper resonant. So how do we differentiate tension pneumothorax with pericardial tamponade where there is fluid in the pericardial space? So the percussion sound will be hyper resonant, whereas in the case of cardiac tamponade the percussion sound will be resonant and the heart sound will be muffled, whereas in the case of tension pneumothorax the heart sound will be normal but just tachycardia. Then breath sounds will be absent in tension pneumothorax on the side which is affected, and in the cardiac tamponade the breath sounds will be present. So these three features we have to understand: the percussion, the heart sounds, and the breath sounds. These are the signs which we have to catch and manage our patient as early as possible. So hyper resonant, this you will be only able to differentiate when you have heard resonant. So it will be more resonant, okay, and the heart sound will be muffled. That means it will be blurred, the heart sound will be blurred. There will be no breath sound in tension pneumothorax, okay. So these are all the clinical features of tension pneumothorax and in comparison to cardiac tamponade, which we'll be seeing in detail in some time. Then coming to diagnosis, although this is a clinical diagnosis, we have to be very careful and understand that this is a clinical diagnosis, because delay you may lose the patient का जान का खतरा रहेगा. Then chest x-ray, डायग्राम में देख लिया है, लेफ्ट निमोथोरैक्स हमने देखा है. देन अल्ट्रासाउंड में हमको क्या दिखेगा, वी कैन सी बारकोड साइन. तो नॉर्मली हमको जो फीचर रहता है सी शोर साइन का वो नहीं दिख के बारकोड साइन दिखेगा, क्योंकि वहां पे जो प्लूरल फ्लूइड है वो नहीं होके एयर आ जाता है. तो लॉस ऑफ सी शोर साइन एंड देयर विल बी स्ट्रेटोस्फियर साइन और बारकोड साइन. You can check this in the images in the Google, it will be very helpful. Then coming to next is the mediastinal shift to the right, that also we can see in the ultrasound and chest x-ray. Collapse of lung, that also we can see in the x-ray. Then coming to management of tension pneumothorax, so it is an emergency condition, so we have to immediately identify and insert a large bore needle in the second intercostal space in children or fifth intercostal space in adults. At what position? So it can be anterior in the mid axillary line or in the mid clavicular line in children. So adults, fifth intercostal space in the mid axillary line, just insert a needle of a large bore like 16 or 18, even that will be helpful. So this where we have to insert the needle and we will be able to save our patient. There is high chance that we'll be able to save our patient. Then after the emergency management, that is the needle thoracocentesis, where we introduce a large bore needle to decompress the tension pneumothorax. Then we go to definitive management, that is the tube thoracocentesis, tube thoracotomy we can also say, that is insertion of intercostal tube ICT in the triangle of safety. So we'll see it in detail. So what happens that the air is coming out and we can improve our patient's health. In case of open wound, we'll close the wound through a gauze and tape it on 3 sides, as we have discussed in the case of a open pneumothorax where there is a wound, okay, and there will be 3-sided occlusive dressing for open pneumothorax. So we put a gauze and tape it on 3 sides. Then updates in the ATLS segment. So flail chest has been removed from life-threatening injuries, and in that case tracheobronchial injury has been added. So but both these are life-threatening, even though immediately not immediately life-threatening. It can be associated with other injuries also, but just flail chest without other injury has been removed from life-threatening injuries, but it is a dangerous injury, we cannot neglect it. So now coming to simple pneumothorax with no hemodynamic compromise, again we will insert a intercostal tube in the triangle of safety, so it will be helpful in releasing the pressure and the air. So how does the simple pneumothorax, what are the other causes? It could be trauma, it could be bulla rupture in the lung. So these are the 2 common causes of simple pneumothorax and can be managed in a similar way. Again, we'll go for pain management, oxygen and all that stuff, apart from the important things which we have discussed. Analgesic, oxygen support, ventilation support, this may be needed. Now coming to hemothorax, we can see in the diagram the white part, the blood is always white on X-ray and CT, we can understand from this, and air is black on CT and X-ray. So we can see the water column or blood column having a upward curvature towards the periphery. So now what happens here is that there is blood accumulation in the pleural space between the pleural layers of the pleural cavity, that is the visceral and the parietal pleura, and it is due to damage to the intercostal vessels or sometimes even lung laceration. It can also cause hemothorax. So what happens? There will be tachycardia, respiratory distress, and fall in BP. These are common findings similar to the above one. So here, but the differentiating feature will be that the percussion note will be dull due to fluid in the pleural space. There the percussion note was hyperresonant in the pneumothorax. Here the percussion note is dull. Dull as in like it will be as comparable to bone. So it will be dull percussion note, and again the breath sounds will be absent. There will be air fluid level in the chest x-ray. That's we can see in the diagram. So these are the clinical features and signs and the x-ray finding. Again, how do we manage this? That we will insert an intercostal tube in the triangle of safety, which will be initial management. And if the patient is very severely injured, so in some cases we will have to go for emergency thoracotomy, that is opening of the chest. And when does we do that? When do we do that? So we insert, or we when do we do this? That is the thoracotomy. We do this in case when there is more than 1 liter blood coming out of the chest tube in within on the insertion itself, and this 1 liter is mainly for penetrating injury. Okay, so 1 liter, more than 1 liter of blood for penetrating injury, and more than 1.5 liter of blood in case of blunt injury. So more than 1.5 liter of blood coming at the from the ICT, that is intercostal tube, in case of a blunt injury. Then if the output of this ICT, intercostal drainage or intercostal tube, is more than 300 cc per hour for 3 consecutive hours, so we will not wait for 3 consecutive hours. Even after 2 hours, depending on the features of the clinical situation, the assessing the patient severity, clinical features, signs and symptoms, we'll finalize where we have to go for thoracotomy, but that is an indication. So more than 300 ml per hour for 3 consecutive hours, the output, the blood output coming in case of hemothorax, then we have to again think of emergency thoracotomy. Other indication, like if there is a aortic injury, if there is diaphragmatic injury, if there is liver and spleen injury, injury to the bronchus, tracheobronchial injury, bronchial vessels and bronchus, there is any hemopericardium or tamponade, there is massive air leak, tracheal injury, bronchus injury causing inadequate ventilation, not able to breathe, the patient is not able to breathe, esophageal injury, thoracic duct injury, open pneumothorax with deranged vitals, we'll again have to consider. Then air embolism, if it has been found out that the patient has air embolism or has a high suspicion of that, then it may also need emergency thoracotomy. Then now understanding some things about emergency thoracotomy or sternotomy. So this is reserved mainly for penetrating injury. So it is generally done, emergency department thoracotomy is done to save the patient's life, and is reserved for patient with penetrating injury like a knife or a bullet shot wound with signs of life, penetrating injury with signs of life, because it is of no use if the patient has been given CPR for more than 5 minutes without endotracheal intubation, like securing the airway, more than 10 minutes with endotracheal intubation, blunt trauma chest with no signs of life at the time of examination. So all these cases it will not be helpful. So the patient should have signs of life and should follow these criteria so that the efforts are useful or fruitful. Then coming to understanding what is the survival rate, it is important because it will be similar in case of, we can understand any injury with hemodynamic compromise. So if the blood pressure is more than 60 mm of Hg, the chance of survival is 60% for this thoracotomy or surgery. In case of more than 40 mm of Hg, the chance of survival is 30%. And in case of, if it is less than 40, then the chance is only 3%. So very less chances of survival. And what is the aim for this thoracotomy, emergency department thoracotomy, which is done in the emergency room, emergency casualty? So what is the aim? To give internal cardiac massage to control hemorrhage from lungs, heart or other chest mediastinal sources, to control massive air leak if it is there, clamp thoracic aorta to preserve blood flow to heart and brain, and vital organs if patient is having major distal penetrating injury. Sorry for the inconvenience, for the disturbance in between, but we'll continue. So how do we assess, how do we approach, what is the access for thoracotomy? So we have various access, but in trauma the most common one is the anterolateral thoracotomy, which is done. So it is done in the fifth intercostal space, the anterior lateral thoracotomy, which is the most easiest and possible versatile incision for emergency thoracic exploration. It is done in the fifth intercostal space, and we can access heart, lungs, descending aorta, pulmonary hilum, esophagus, and all these things are accessible. In case other incisions, we should know that there is a posterolateral incision again in the fifth intercostal space. Then there is a clamshell incision for both thorax axis. Then hemiclamshell, also known as trapdoor thoracotomy or median sternotomy. So these are various accesses. So what is the other features of these other accesses? So in case of posterolateral thoracotomy in the left side, it will be helpful for lungs, pulmonary vasculature and hemidiaphragm. And in the right side, it will be showing us the proximal and the mid esophagus with trachea and main stem bronchi. In case of median sternotomy, it will give us exposure to heart, ascending aorta and aortic arch, right side of the arch vessels and the pulmonary vasculature. And in left thoracotomy, it will give us access to the distal esophagus, the lower esophagus, left side of lung, left ventricle, descending aorta, left subclavian, almost similar to left posterolateral thoracotomy. Then anterolateral thoracotomy, which is already discussed, which will give us heart, lungs, descending aorta, pulmonary hilum and esophagus. So we can manage these injuries. Then clamshell for exploration to the both cavities and mainly heart and mediastinum. Trapdoor thoracotomy for left subclavian artery repair. Trapdoor also known as hemiclamshell. And median sternotomy, also it can be done with cervical extension extending to the neck for proximal subclavian, innominate and carotid vessel exploration and repair. So these are some of the access for chest thoracotomy. Now coming to chest tube. So chest tube are very common aspect of surgical practice, so it has to be understood very carefully, and the basics should be known by medical MBBS doctors, and it is very commonly asked in the exams also in case of final MBBS. So it is very important to understand this very carefully. So it is inserted, the chest tube is inserted in triangle of safety. The chest tube is just a tube of 14 French. So it is inserted in the triangle of safety. Then coming to boundaries. So what are the boundaries? So anterior axillary fold. On the anterior side, the posterior axillary fold on the posterior side, and the apex in the axilla, base formed by the fifth intercostal space. So anterior border can be marked by the axilla, apex of axilla, and the lateral border of the pec major, pectoralis major, and the posterior one, the lateral border of the latissimus dorsi. So these will form a triangle. The lower base will be the fifth intercostal space, the rib by the sixth rib. So this is the triangle. So here we go for incision and then we place the tube after securing the access. When we insert a chest tube, so these are skin, the fascia, superficial and deep, serratus anterior muscle, the three intercostal muscles, endothoracic fascia, and the parietal pleura. So what is the procedure in insertion of the chest tube? The chest tube, after insertion, first we secure it by fingers. We bluntly making the, after making the incision, we bluntly insert the fingers, and with help of blunt artery forceps, and we make the puncture, or we can directly use a chest tube with a trocar, which will be easier, that can be done. So chest tubes is again, after inserting, is connected to the underwater seal bag to prevent air entry in the chest again. So we'll be penetrating skill muscle and pleura. So we'll go for a blunt dissection of the pleura with help of the digits, and into the tract into the pleural space, then withdraw the central trocar and position the drain. And we have to ensure that the distance of insertion, gauging the distance of insertion, so it should be not too inside and too outside. The eyes of the tube should be inside, because it can again cause further increase in pneumothorax or hemothorax. Then suture placement, we secure it by purse string suture and then connect it to the underwater seal, underwater air seal. So how do we check whether our chest tube is functioning properly? So there will be air column moving, the fluid column, air fluid column will be moving in the tube, which is connected to the underwater seal. So that air column will be moving. So position of chest tube will be again confirmed by X-ray, and based on the break in the radiopaque line which denotes the holes in the chest tube, we have to note that the holes in the chest tube, the eye part, is inside the thoracic cavity, because it will otherwise cause further leak and cause further problem. And how do we remove chest tube? During removal, we have to remove the chest tube when the patient is at the peak of expiration, peak of inspiration, and we have to ask the patient to hold the breath. So the lungs will be having the maximum capacity and the chest will be having the maximum capacity, and it will be expanded. So at that point we will remove the chest tube. At the peak of inspiration, एकदम सांस लेके सांस रोक लिया, breath hold कर लिया, at that point we will be removing the chest tube. Then how do we check the chest tube is removed? When do we remove the chest tube? So when the lungs has expanded, where there is proper breath sounds, the X-ray is easily suggestive that the lungs have expanded. During that, we can understand that the lungs have expanded, or the output from the chest tube, the drain from the chest tube is less than 100 ml in the last 24 hours. So when the output has become less over time, then we remove the chest tube, and again we remove it at the peak of expiration by holding the patient's breath, by asking the patient to hold breath. Sorry for the interruption. We'll continue. Cardiac tamponade. So what is cardiac tamponade? It is seen in the diagram, the enlarged heart borders. So there will be fluid or blood in the pericardial space. That is sudden accumulation of blood or fluid, but most probably it is blood. It is blood in the pericardial space. So rapid accumulation of blood in the pericardial space. So even 60 to 70 cc of blood can cause pericardial tamponade or spray tamponade, and it is generally due to trauma, and it commonly is penetrative or even blunt trauma. So what are the clinical features? As we can see in the diagram, clinical features are also commonly known as Beck's triad. So what is Beck's triad? So there will be BP is less, so hypotension. So because decreased cardiac output, the heart is not able to expand, the blood cannot come in, so there will be impaired diastole, diastolic filling. then decreased systolic blood pressure, BP is low, hypotension, then and tachycardia. To function, to survive the patient, to supply blood to all the vital organs, there will be tachycardia to maintain the cardiac output because the diastolic volume is low, the end diastolic volume is low. So to maintain the cardiac output, there will be tachycardia, there will be raised jugular venous pressure, JVP will be raised, distended neck veins, and muffled heart sound. So these are the features. So hypotension, tachycardia, and raised GVP. These are the common features, and muffled heart sound on auscultation. Then how do we diagnose? Mainly it is diagnosed clinically, but have to be differentiated from tension pneumothorax. We have already discussed that here there will be breath sounds will be positive, the percussion will be resonant in the lungs, and in the heart region there will be muffled heart sound. The heart borders will be increased in percussion, the heart cardiac dullness will be increased in percussion. Then coming to next, the E-fast and X-ray will help us in quickly confirming the diagnosis. So probe placed in the epigastrium, so we'll get to know hypoechoic collection, that is less echogenicity on the ultrasound, that is it will be blackish. Then how do we manage this? Also in the X-ray we can see that the cardiac borders have been increased. Now management in case of emergency, we'll go for a needle pericardiocentesis. In emergency, we'll go for a needle pericardiocentesis. So what do we do here in needle pericardiocentesis? We take a needle and under ECG or echo control, we insert it at subxiphoid space at the angle of 45 degree to the horizontal to the skin, and the direction is towards the left shoulder tip. So at the subxiphoid space at 45 degrees angle, we direct it towards the left shoulder tip. So, and we go on aspirating while we go inside, and as soon as we aspirate blood, we stop and keep aspirating so that the blood in the pericardial space is removed, and even 10 cc of blood will improve the hemodynamic status of the patient because the heart will get space to expand and accumulate blood for its function, that is the systole and diastolic volume. So that volume will increase, it will be able to relax better and accumulate blood for maintaining cardiac output. So this will help. Then again coming to definitive management, in emergency we can go for left anterolateral thoracotomy, and if there is any cardiac tear then we can repair that. So if there is a atrial laceration, we will grasp it with a Satinsky clamp and close it with continuous monofilament permanent sutures, that is non-absorbable sutures. Monofilament, that is single filament, we'll discuss it in detail in the coming lectures. Then ventricular laceration, we need to close it by horizontal mattress suture, and it should be supported, reinforced with pledgelet, that is will be supporting it in the form of pledgelet that will be supporting the wound, and horizontal mattress again it will be with permanent non-absorbable monofilament sutures, and these pledgelets are used to prevent cut through the injury. And the suture which we are commonly using is 20 or 30 prolin. In case there is some valve injury, valve abnormality, it will also need urgent repair. And lastly, we will insert a pericardial drain. So this is about emergency definitive management of cardiac pericardial tamponade with cardiac injury. Then coming to traumatic aortic injury, it can happen following blunt or penetrating injury. Again, this what is the site of injury here? It is the left subclavian artery that is distal to the ligamentum arteriosum. So left subclavian artery that is distal to ligamentum arteriosum. Again, what will be the findings? Clinical feature will be chest pain and absence of pulsation in one limb, difference of blood pressure in both the limbs. X-ray will be showing widening mediastinum. We can see here there is widening of mediastinum, depressed left main stem bronchus. Depressed left main stem bronchus can be seen. What are the other findings? Like the apical cap, we can see here the apical cap, loss of aortic knob, and other are like the abnormal aortic contour, which you can see deviation of the left main stem bronchus, and tracheal shift and nasogastric shift, nasogastric tube shift. So all these things are features of uh, aortic injury, and to confirm or the diagnostic investigation of choice is CT angio, CT chest. Due to high incidence of missed injury in stable patient, it can be delayed and cause difficulty later. And in case when the patient is unstable, we can go for a transesophageal echocardiogram because that will need emergency management. So transesophageal echocardiogram. So this was about aortic injury, the findings in the imaging. Then how do we manage this? So initially we will go for permissive hypotension so that the blood pressure is not more, so that there is more bleeding. So we have to be careful, maintain the BP towards the slightly on the lower side, that is 90 to 100. Then we will give short acting beta blocker so that the heart rate is controlled, the heart rate is kept below 80. Blood pressure is controlled with mean arterial pressure, that is 60 to 70, and the tear in the aorta can enlarge as the BP increases. So we have to be careful while giving fluids. So we have to take care of permissive hypotension so that the bleeding does not increase. So now we'll go for a repair, that is graft repair, which is most commonly done, and we can also use endovascular technique or a open technique, endovascular technique or open technique, and the graft is Dacron graft, which is commonly used. Then just knowing about the grades of these injuries. So what is grade 1 of this aortic injury? It is intimal tear. So there will be non-operative management in this. Only the beta blocker will be helpful. Then grade 2, there is intramural hematoma. Again, it will be non-operative. We will be observing the patient. If needed, if the size of hematoma increasing, then we may need to intervene, but commonly it is not needed. So observation. In grade 3, if there is pseudoaneurysm, we go for an endovascular stent in case of pseudoaneurysm. Then in full thickness transaction, it is fully cut or rupture, then we have to intervene and use graft to repair, that is Dacron or PTFE graft, through the left thoracotomy, left anterolateral thoracotomy, or even sometimes left posterolateral thoracotomy. So these are the grades and something about its management. And in case of penetrating aortic injury, when there is simple laceration, then we go for aortorrhaphy in the anterior wall. In case of postural laceration, we have to repair it with cardiopulmonary bypass. So it's a major major surgery which requires cardiopulmonary bypass, like cardiopulmonary heart lung machine it needs, so that the blood can be bypassed and again circulated in the body with help of a machine. And in case of innominate artery injury, it is treated by bypass exclusion technique, where we use a PTFE graft and anastomose it side to side to the proximal in uninjured part of aorta, and then tunnel it below the pulmonary vein to reach the uninjured part of the innominate artery, and we secure it with end-to-end anastomosis after ligating the proximal end. So always remember that innominate artery we use a bypass exclusion technique using a PTFE graft, okay, where we connect the aorta to the innominate artery below the pulmonary vein. Then coming to sternal fractures, so these are caused by high velocity impact, can lead to cardiac contusion and cause increase in cardiac enzyme, and we'll monitor the patient through ECG, and generally we don't need surgical management for these cases. In case there is more damage to the heart and it has caused some effect or is needed repair or causing pericardial effusion, pericardial cardiac tamponade, then we'll need intervention. So we have to be careful regarding that. But generally it is not required and patient can be monitored and managed conservatively. Then coming to traumatic diaphragmatic injury, that is diaphragmatic injury. So it is can be seen again in blunt and penetrating injuries and is more common on the left side because it is protected by liver on the right side. And due to the injury to the diaphragm, the bowel, that is intra-abdominal, will come in the thoracic cavity. And what we see here is Burgess triad in these cases, like that there is fracture rib, fracture spine or pelvis, and diaphragm rupture. So this is Burgess triad, that is fracture rib, fracture pelvis or spine and diaphragm rupture. And most common organ coming up is stomach followed by colon. So then coming to penetrating trauma in nipple to coastal margin, we have to think that there is a possibility of diaphragm getting injured. So if there is penetrating injury in nipple to coastal margin, then there is a high chance that there is diaphragmatic injury. Then most diaphragmatic injuries are silent and they present late with herniation of abdominal content. So we have to be careful while we are assessing patient if there is trauma in the region of nipple to coastal margin. Then clinical features. So what are the clinical features? It could be breathlessness and bowel sounds in the chest. These are some of the clinical features. Again, pain and all that will be there, decreased saturation and all, but mainly breathlessness and bowel sound in the thoracic cavity. And how do we manage these? It is managed by abdominal surgery, that is laparotomy, regardless of the tear size. So it has to be repaired. Whatever be the tear size, it has to be repaired. Okay. Then we reduce the bowel, take it down in the abdomen, then repair the diaphragm with Prulin sutures. Insert intercostal tube in chest to drain if any content accumulates there. And you have to always note that we only go for abdominal approach and not the chest. Then bag and mask ventilation should not be done because air may enter stomach and cause more compromise. So ventilation is, if needed, it must be done by ET tube. So it should not be done by bag mask ventilation because it can further compromise the patient. Then coming to diaphragm. So it's a thin muscle. Diaphragm is a thin muscle which divides chest and abdomen, and injury can cause abdominal organ to go into chest. So in case of blunt trauma, the defect is generally larger than penetrating trauma. So how do we go for this in this surgery? That the incision that is given for diaphragm for this repair, that is known as phrenotomy, and the safest is the peripheral circumferential incision. Peripheral circumferential incision, and it takes care of the phrenic nerve, and we have to be careful regarding injury to the phrenic nerve. So now coming to junctional zone. So what are the junctional zone? Junctional zone are area between the nipple and the rib cage. So here the injury can lead to abdominal injury and thoracic injury. So both the areas can be injured. Then lastly, coming to neck trauma, which we have already discussed yesterday, but we'll just quickly go through it. So zone 1 is the lower part from the sternum to the cricoid cartilage and is associated with maximum mortality. Cricoid cartilage to the angle of mandible, which is the most common exposed zone and most commonly injured and is surgically accessible. And angle of mandible to base of skull, which is zone 3. And most of these injuries, if it is not bleeding continuously, then can be managed conservatively. In 20% case, we need intervention. So what are the some signs? That is expanding neck hematoma, hoarseness of voice, change in voice, air bubbling from the penetrating wound, that means there is connection to the respiratory passage, and increasing subcutaneous emphysema. So this subcutaneous emphysema, the crepitus is increasing over time due to connection through from the airway passage, that is the respiratory passage, causing increase in subcutaneous emphysema. So generally we have to manage the patient depending on the scenario as per the vitals, but generally zone 2 is surgically explored, and zone 1 and zone 3 they will be first tried with angiography and will require imaging, especially when the patient is stable, and can be tried with embolization, and if all fails then we'll have to go for surgical exploration. Now just going through the penetrating trauma pathways or management protocol. So we'll first go for the primary CABC, that is hemorrhage, ABC, airway, breathing and control, circulation, and if the patient is suspected to having cardiac arrest, then we may need a emergency department thoracotomy, which we have already discussed. If the patient is stable, then we'll go for some detailed examination of the chest and the chest radiograph. If the patient is having pneumothorax or hemothorax or something like that, then we'll go for a tube thoracostomy, that is IC, intercostal tube insertion in the safety triangle in the fifth intercostal space. If there is no need, then we'll consider if there is injury to the cardiac box or transmediastinal injury. If that is there, then we'll evaluate mediastinum in the with the help of echocardiography, chest CT, bronchoscopy, esophagoscopy. And if there is no, then we'll just monitor the chest tube output and manage the patient accordingly. If the patient is unstable, we'll start resuscitation as soon as possible. We'll examine the patient, start detailed examination, and if needed, tube thoracostomy if the breath sounds are decreased. So that means there is a possibility of either pneumothorax or a hemothorax. If the chest output is more, that is more than 1500 ml and ongoing, then we'll go for a thoracotomy and again manage the patient, continue resuscitation. If the output is not more, then we'll go for further examination, that is the EFAST, the pericardial ultrasound. If that is positive, again it will be going for sternotomy or emergency department thoracotomy. If that is negative, EFAST is negative, whether the patient is responding to the resuscitation, so we are giving fluid, whether the patient is a transient responder or a non-responder, according to that we will decide further if there is any need of further intervention. If the patient resuscitation is responsive, we will just go for monitoring the chest tube output, monitoring the output of the ICD, intercostal tube, and will further evaluate patient for other injuries either in the mediastinum or abdomen. And if there is no resuscitation responsiveness, the patient is not responding properly, then we go for OR, operating room, for the pericardial window and continue resuscitation and take him the patient for thoracotomy and manage the patient on the basis of thoracotomy. So this will be a damage control approach. These are slightly higher level where we will be needing to control the damage. We'll be going for pulmonary control, vascular control and all that things, and cardiac repair is as per need. So all these things will be seen in damage control for thoracic trauma. But this is basics and this should be known for solving questions, and some basics should be known so that active efforts, quick efforts can be taken, and in case you are in emergency you can line up the patient with the cardiac surgeons, thoracic surgeons, so that the patient can be saved earlier. So thank you for watching, and if you have liked the video, please like, share and subscribe, and keep studying, keep growing and never give up, because great things take time. And see you soon in next video, and thank you once again, and sorry for the disturbance for today, but was unavoidable. Still thank you very much.